It's a pleasure to be here, and this is a really fun topic because there's not a lot of great evidence, but there's a lot of opinions and a lot of debate. So I'll ask that we hold questions and comments to the end so we have time to get through everything, and then I would love to hear your questions and your thoughts. I have nothing to disclose. So pregnancy, what a breeze, right? Just such a beautiful time in a woman's life, filled with joy and excitement. You're feeling great, you're glowing, they say. I think this is more the reality of a lot of our pregnancies. A stressful time, uncomfortable, and a time filled with anxiety. I think pregnancy can actually be described as a 9-month anxiety-a-thon without any of your usual coping mechanisms. And part of what drives the anxiety for pregnant women is the amount of warnings and contraindications that they're constantly bombarded with. Everybody from their mother to their neighbor to random people in the grocery store are stopping them and telling them everything they should and shouldn't be doing, eating, drinking, or taking. And I think emergency physicians, we share that anxiety when it comes to taking care of pregnant patients. So much is unknown. Is this test indicated or not? Is this medication safe or not? We like to practice evidence-based medicine, but unfortunately when it comes to pregnancy, a lot of evidence just isn't there. And the truth is, it probably never will be there. If you're waiting for the double-blind, randomized, controlled, placebo-controlled study on what causes birth defects, that study's never coming. Most of our literature comes from expert opinion, case reports, case controls, and often it contradicts each other. So what we're going to do today is sort through the data, or the lack of, to try to reach some reasonable conclusions that you can use in your everyday practice of the care of pregnant women in your emergency department. So our roadmap for today, we're going to be talking about 3 areas of controversy and confusion: the use of Rh immune globulin and prophylaxis against Rh sensitization in the first trimester, the use of antiemetics in nausea and vomiting in early pregnancy, and the D-dimer, and can it be used to rule out venous thromboembolism in pregnant patients. For each of these topics, we're going to start with what we know for sure, then discuss the areas of controversy and confusion. We'll review the evidence, or the lack of in some cases, and then I'll finish by sharing my suggested practice. And suggested is highlighted because that's all it is. It's a suggestion. It's my personal practice, having reviewed the literature, but certainly, as I mentioned, the literature here is pretty skimpy, so I think it's hard for anyone to say they have a best practice. So I'm simply presenting my suggested practice to you. And we'll start with the use of RHIG for first trimester complications. So what we know for sure that Rh-negative women, when they're pregnant with a Rh-positive baby, are at risk for becoming sensitized if they're exposed to fetal blood. What happens in the case of a fetal maternal hemorrhage, for example, in the case of placental abruption, mom is exposed to fetal blood. The first time, though, she makes IgM antibodies, which don't cross the placenta. This is why the first pregnancy is often not affected. But if a second exposure happens, now mom makes IgG antibodies, which do cross the placenta. Those antibodies can attack fetal blood cells, leading to fetal anemia, hemolytic disease of the fetus or newborn, and in severe cases, hydrops fetalis, which can lead to pregnancy loss and death. The good news is we know for sure that this is preventable by giving RHIG prophylaxis to an Rh-negative mom after exposure. We know for sure that the larger the fetal maternal hemorrhage, the higher the chance that mom is going to become sensitized. By far, most of these sensitizations occur at delivery, more than 90%. So what obstetricians do now is they routinely prophylax Rh-negative women, first at 28 weeks with RHIG, and then again within 72 hours post-delivery. So what is controversial about this? Well, the question has been raised, do Rh-negative women with first trimester complications need RHIG prophylaxis? We said that the larger the fetal maternal hemorrhage, the more likely mom is to become sensitized. We know that any fetal maternal hemorrhage in the first trimester is going to be very, very, very small. So is prophylaxis necessary? Can sensitization even occur? Well, how small are we talking? At 12 weeks, the entire blood volume of the fetus is 4.2 milliliters. So even if that fetus lost all of its blood completely out, mom still would only be exposed to a very small amount of fetal maternal hemorrhage. That said, we know that as little as 1/1000th of a milliliter can sensitize some individuals in some studies. So what is the evidence for giving RHIG in first trimester complications? Well, there's only one randomized controlled trial, and I bet this is probably the only one we'll ever have. It was done in 1972, and they looked at Rh-negative women following spontaneous miscarriage that occurred in the first 12 weeks. 19 of those women received RHIG prophylaxis, 29 were given placebo or nothing. None of the women in the group were sensitized. The only randomized trial that we have. The rest of the evidence is case control studies, a series of case reports, but mostly it's a lot of reviews and it's a lot of expert opinion. There was a 2013 Cochrane review on the use of RHIG for spontaneous miscarriage in the first trimester, and the authors concluded that they couldn't make a conclusion because there wasn't enough data. They recommended that we just follow the standard practice guidelines for each of our individual countries. Well, what are our guidelines? Well, in 1999, the American College of Obstetrics and Gynecology stated that they recommended RHIG prophylaxis be given to all Rh-negative mothers within 72 hours of any of the following events: miscarriage, including threatened miscarriage, ectopic pregnancy, and molar pregnancy. Now, they reaffirmed these guidelines in 2016, and they did back off somewhat, acknowledging that this is an area of controversy, the literature's not great, they weren't as firm as they were in their prior guidelines, and recommended that you kind of do what everybody else is doing and follow the practice culture in your region. However, in their other guidelines that they recently introduced as far as spontaneous abortion and the management of early pregnancy loss, in those guidelines they do say that checking an Rh status is the standard of care and patients should be treated appropriately. And also on their website for patient information under miscarriage and early pregnancy loss, for the patients they say that they should expect to receive a shot of RHIG prophylaxis if they're Rh negative following their miscarriage. So I think what they're really saying is they're sticking to their original guidelines, but they backed off a little bit in their wordage in their 2016 update. If you're going to follow these guidelines, what dose should you give? Well, the 50 microgram dose is enough to neutralize 5 milliliters of blood. And remember, we said that the entire blood volume of the fetus at 12 weeks is only 4.2 milliliters, so the 50 microgram dose is enough for a patient in the first trimester. However, that dose isn't very readily available. I know my hospital doesn't even stock it. We only have the 300 microgram dose, and there's no harm in giving that dose if it's more readily available, but the 50 microgram dose is enough. So these seem like relatively straightforward recommendations if you choose to follow them, but I can think of a few instances in the emergency department where this gets confusing. So what if it's been more than 72 hours? They recommended it within 72 hours of exposure. What if she's presenting beyond that? Well, I would say to give it anyway. There is evidence of benefit up to 13 days post-exposure, and a lot of authors recommend within 28 days of exposure. What about this? The patient comes back. She was seen 2 weeks ago. She had vaginal bleeding. She was given an RHIG prophylaxis shot, and now she's back bleeding again. Do we have to redose her? The answer is no. The RHIG half-life is around 24 days. So if she's anywhere between 3 and 6 weeks of having received her first prophylaxis shot, there's no need to redose. Then what about this one? I feel like this is a really tricky one. She says she's not having bleeding, but then she gives a urine sample and it's grossly bloody. What do you do with that situation? Again, this is a really tough one, and it depends on how conservative you want to be. I tend to still treat these patients because I have chosen to be extra conservative on this. So the question often comes up, is there harm? And the answer is not really. It is made from human plasma, so there's a theoretical risk of disease transmission. However, apart from a batch in the 1970s that was contaminated with hepatitis, there hasn't been any other reports of contaminated doses or disease transmission from RHIG prophylaxis. And as far as other adverse events that we can see with any medication, it's actually very, very, very safe. It's exceedingly rare for anyone to have a negative, like adverse allergic reaction to RHIG. So there's very little, if any, downside. Well, what about the cost? People mention this a lot. And my first argument would be it really doesn't come up that often. The vast majority of women are Rh positive in all races. So as many first trimester complications as we see at our shop, it's really only every few months that I find myself faced with this question. And then my second response to the cost question is consider the cost of one pregnancy affected by Rh incompatibility. As soon as mom's sensitized, that's a high-risk pregnancy. She needs to be followed closely and have antibody titers followed closely. She needs to have frequent ultrasounds. At delivery, her baby might require intensive care. She could lose the pregnancy. So there's a lot of risk here, and there's a lot of downside for a woman that becomes sensitized. So my suggested practice and my personal practice is I give RHIG for all Rh-negative mothers up to 28 days post-exposure following ectopic pregnancy, miscarriage, including threatened miscarriage, and molar pregnancy. Because my hospital only carries the 300 microgram dose, that's what I give. There's no harm in doing that. If your hospital carries the 50 microgram dose, that's appropriate as well. So next we'll move on to the use of antiemetics for nausea and vomiting in early pregnancy. So what do we know for sure? We know for sure that nausea and vomiting sucks. It's completely miserable, and it's really miserable if it goes on for weeks or even months at a time. We also know that nausea vomiting in pregnancy is very common. Up to 70 to 80% of pregnancies are affected by nausea vomiting. Usually begins around 6 weeks, peaks somewhere between 7 and 12 weeks, and for most women, fortunately, it resolves between 14 and 16 weeks, but you're still looking at a lot of weeks there of feeling pretty miserable. For an unfortunate 1 to 3% of women, they go on to develop hyperemesis gravidarum, which is protracted vomiting, weight loss, ketonuria, electrolyte disturbance, and dehydration. We know for sure that nausea and vomiting causes significant maternal morbidity, and I really want to emphasize this because I think this gets to the heart of the antiemetic discussion. Women that have nausea, vomiting, or hyperemesis in their pregnancy are more likely to be depressed, more likely to experience anxiety. It's a significant stressor on her family, especially if she already has small children at home that she's trying to take care of. She might have to miss work. She might need to be hospitalized. In fact, hyperemesis is the #1 cause of hospitalization for women in early pregnancy. And she might be forced to disclose her pregnancy before she's ready. Maybe she doesn't want her boss and her coworkers to know that she's pregnant yet, but if she's puking in the staff lounge, the secret's going to be out. You might remember a few years ago when Duchess Kate Middleton was hospitalized in her first pregnancy for hyperemesis, very early in her pregnancy, right around 6 or 7 weeks, and this was the headlines. I mean, imagine you at work and this headline going around, early pregnancy, if you're not ready for people to know that. We also know for sure that medication works. There's evidence that all of these medicines, including some others, have benefit in the treatment of nausea, vomiting in early pregnancy. We also know, though, unfortunately, that the period of nausea and vomiting coincides with the period that the fetus is most sensitive and vulnerable, the period between 2 weeks and 15 weeks when organogenesis and the fetal growth period is occurring. So this leads us to the question, do antiemetics cause birth defects? And of course, when I say antiemetics, I'm talking specifically about one, ondansetron, or the brand name Zofran. Now, the early studies of ondansetron were very promising, and they showed that it was safe and effective in the treatment of nausea, vomiting, and pregnancy. It became so popular that at one point it was estimated that 1 in 4 pregnant women in the United States was given a prescription for ondansetron. So what happened? Well, there's several stories. We only have a little time or studies. We only have a few time today, so I'm only going to talk about 3. But the first one that caused some controversy was by Andrica and colleagues in 2012. And they reviewed cases of 4,524 pregnancies that were exposed to a drug, some drug, antiemetics, GERD medications, antihistamines in their pregnancy, and they compared those to 5,000 pregnancies that were exposed to no drugs. They were specifically looking for 4 birth defects: cleft lip, plus or minus cleft palate alone, hypospadias, or neural tube defects. So they found a 2-fold increased risk of cleft palate alone in babies that were exposed to ondansetron. Now, the caveats here is the sample size was very small. Of those 4,000 infants that were exposed to a medication, only 55 were exposed to ondansetron. However, 11 of those did develop a cleft palate for an odds ratio of 2.37. Another interesting thing about this study is Reglan actually had that same odds ratio, but the sample size was even smaller, so it wasn't reported. Furthermore, no other studies have shown this. Another study that gets quoted a lot is by Danielson and colleagues in 2014. In this study, they looked at 1,300 infants exposed to ondansetron. They found there was no increased risk of major malformations, including cleft palate, but they did find there was a slightly increased risk of cardiac septal defects. But what most experts consider to be the best article was by Pasternak and colleagues in 2013 and published in the New England Journal. They reviewed more than 400,000 pregnancies, more than 1,200 were exposed to ondansetron, and the authors found no significant increased risk in spontaneous abortion, stillbirth, any major birth defect, including cleft palate, of which there were 0, preterm delivery, or low birth weight. So how do you put this together? Our friends at the American College of Obstetrics and Gynecology have given us some more guidelines. In 2015, they released guidelines on the management of nausea, vomiting, in early pregnancy. Their recommendations, actually their first-line recommendation is lifestyle modifications. So eating small meals frequently, chewing on saltine crackers, avoiding noxious smells that trigger you to feel nauseous and vomiting. And if your lifestyle modifications don't work, their first-line medication recommendation is pyridoxine or vitamin B6 and doxalamine. Now, this is a great example of medicine coming full circle, and what's old is new again, because that drug combination was marketed under the brand name Bendectin in the 1970s and 80s, and it was the leading treatment for nausea, vomiting, and pregnancy. However, it was pulled off the market after concerns for birth defects, which later were unfounded, and now it's back under the brand name Diclegis. Same drug. So if you're a gynecologist and you're seeing your well woman in her first trimester well woman visit, she feels great, you're talking to her about nausea, vomiting, your recommendations are going to be lifestyle modifications and maybe the combination of pyridoxine and doxalamine. But that's not what our patients look like, right? These are our patients. So I dare you to talk to this woman about lifestyle modifications. She's in the ER because saltine crackers aren't working, and she's trying to avoid noxious smells, and she's miserable. So what do we do for our patients? And so my suggested practice is, if she hasn't tried anything yet, I think it's reasonable to start with the same first-line recommendations as ACOG, and that's the pyridoxine plus doxalamine. And if her insurance covers it or she can afford it, I think there is a slight advantage to prescribing the brand name because it's a delayed release formulation as opposed to the over-the-counter formula, which is immediate release and associated with more maternal side effects such as drowsiness. But it can be expensive. It's not covered by all insurances. So you can certainly write for the two medications separately, or these are also available over the counter. And I give them a prescription for ondansetron. If they haven't tried anything first, I give the prescription for doxalamine and pyridoxine, but I send them home with a second agent too, because for a lot of women, they don't find that the first drug is effective enough. I think ondansetron is safe. I think it's effective. And you can also prescribe it in the oral disintegrating tablet form, which is, to me, almost the same as giving an IV. So if they're unable to keep anything down, they're vomiting, the ODT form is going to be helpful for her. Also, ondansetron is associated with less maternal side effects such as dizziness and drowsiness and sleepiness. So my suggested practice, if she hasn't tried anything, try her in the first-line combination, pyridoxine and doxalamine, and give a second agent. I personally give ondansetron. If you're not comfortable with that, other second-line agents, you can give diphenhydramine, Reglan. A third-line agent I consider promethazine. The advantage to this is you can give it rectally if she's having difficulty keeping anything down, but that's where I think the oral disintegrating tab of ondansetron is helpful for us. So finally, we'll finish with probably the most controversial topic of all, the use of D-dimer, ruling out venous thromboembolism in pregnancy. So what we know for sure, pregnant patients are at risk for venous thromboembolism. They're at least 5 times, maybe up to 10 times more likely to get a clot than a non-pregnant person. Their highest risk is in the 3rd trimester. More than half of PEs occur in the 3rd trimester and immediately postpartum. We also know that clots kill pregnant women. PE is the leading cause of maternal mortality in developing countries, including the United States. We also know for sure that PE is an incredibly difficult diagnosis to make in pregnant patients. One, because the signs and symptoms overlap with those experienced in normal pregnancy. It's physiologic for her heart rate to go up. Everyone, especially at the end of their pregnancy, feels short of breath. Their legs are probably swollen. Because this is such a hard diagnosis to make and the stakes are so high, we tend to rely really heavily on imaging. The incidence of PE is only 5% or less in pregnant patients that were imaged compared to 20 to 25% of non-pregnant patients. So we're imaging a lot and we seem to have a pretty low threshold for doing so. We know for sure that we desperately need another way to risk stratify pregnant patients for PE. So what about the D-dimer? We know that the D-dimer is sensitive for ruling out venous thromboembolism in non-pregnant patients, but it's never been validated in pregnant patients. We also know that the D-dimer rises steadily throughout pregnancy, and at the time of delivery, essentially 100% of women will have an elevated D-dimer. So the controversy, can D-dimer be used to rule out PE in pregnant patients? The question I think we're really asking here, though, is how can we better risk stratify pregnant patients for PE? And I think there's a couple ways, and I think one way is by trimester. So in the 1st and 2nd trimester, her risk of PE is still elevated. It becomes elevated from the beginning of pregnancy, but it's still not quite as high as the 3rd trimester or immediately postpartum. Now, if you were to send D-dimers on women in their 1st trimester, 50 to 80% will still have a negative D-dimer. In the 2nd trimester, 22 to 33% will still have a negative D-dimer. Some authors feel that a negative D-dimer is probably acceptable for ruling out PE in low probability patients. So how do we decide if she's low probability? This is where it gets so tough because we just said that pregnant women are at increased risk of PE starting at the beginning of pregnancy. That's true, although I do think there's some role for us to use our history, our physical, our overall gestalt, and we can still use vital signs. So it is physiologic for heart rate to increase in pregnancy, but it really only goes up 15 to 20 beats per minute, and that peaks around the end of the 2nd trimester. So if you're seeing a patient whose heart rate is 130, 140, you cannot write that off to her being pregnant. It can go up a little bit, but not that much. But I think you'll find that the most helpful vital sign is her oxygen saturation. Because while many pregnant women will feel short of breath, there's no reason they should be hypoxic. There's really not. So if you have a pregnant patient with unexplained hypoxia, that's always concerning, and I think too high risk to even consider using a D-dimer. What about 3rd trimester patients? Well, now the risk of PE is the highest. More than half occur in the 3rd trimester. If you were to send a D-dimer, almost none of them would have a normal D-dimer anyway. And in my opinion, 3rd trimester pregnant patients are just too high risk and should move directly to imaging. Well, what about the trimester-adjusted D-dimer? We've heard a lot about this. There's a lot of studies on it, at least 6. They all use different methods, and they all reached different results. as far as what is considered a normal D-dimer in pregnancy. And even if we do establish a normal range, we still haven't established the safe exclusion threshold for ruling out PE. So I think there's some promise here. I don't think it's ready for prime time yet. Well, what about all of our decision rules, our Geneva score, our PERC rule, our Wells criteria, other great decision tools? None of them have been validated in pregnant patients. What about some combination? A lot of authors are starting to look at this now, combining a decision rule with a D-dimer to risk stratify our patients. One study by Peril and colleagues looked at 59 women. 17 of those women were diagnosed with PE. They sent a trimester-specific D-dimer, and it's unclear from the article how they reached their trimester-specific levels, and they combined it with the modified Wells score. They found that using both the trimester-specific D-dimer and the modified Wells was 100% sensitive and 74% specific if either result was abnormal, and all patients in this study that had PE would have been imaged. Again, there's some promise here, but I don't think this is quite ready for prime time. What about guidelines? What about our friends at ACOG? They like to make guidelines about everything. Well, for D-dimer, all they've said is that it's less reliable in pregnancy. They haven't come out and said you can or cannot use it when risk stratifying pregnant patients. They simply say it's less reliable. Other organizations, though, have released guidelines. The American Thoracic Society released some guidelines that they made based on a panel of experts that they brought in, including leaders of ACOG were on that panel, and they determined that D-dimer should not be used to rule out PE in any pregnant patient. So this is a tricky one. This is my suggested practice and what I tend to do in real life for first and early second trimester patients that I feel overall are low risk based on their history, based on their physical, based on my overall clinical gestalt, and based on their vital signs. And they have a negative D-dimer that's probably sufficient for ruling out PE. For patients in third trimester that are postpartum, that are hypoxic for any reason, I personally feel that's too high risk, and you shouldn't even consider D-dimer and should move immediately to imaging. So just to summarize these three topics, my suggested practice for Rh-negative mothers that are exposed to miscarriage, ectopic pregnancy, or molar pregnancy, they be given RHIG prophylaxis within 28 days. The 300 microgram dose is the more readily available dose. Pyridoxine and doxalamine is first line for nausea and vomiting treatment in pregnancy. I think this is a reasonable place to start, but I send my patients home with something else too in case this doesn't work. And for me, I'm comfortable giving ondansetron, but there are other options that you can give if you don't feel comfortable. The D-dimer probably okay for patients that are low pretest probability in their first and early second trimester, but patients in the third trimester that are too high risk, and also any pregnant patient that's hypoxic, also too risk, and I think should move directly to imaging. So I thank you very much. I'm sure you have a lot of questions, and I'd love to hear your comments or questions now.